am going to start out by introducing the first question in about 30 seconds here.
And Andrea, Tammy sent us an email with questions also that just came through.
Got that too. Thank you so much. I'm just going to do a little intro here. My name is Andrea Mazoris. I am the Senior Director for Revenue Integrity at OHSU Health and the current chair for Oregon HFMA Problem Solving. And I had the great opportunity to work with Caitlin as the prior chair. And maybe Caitlin, if you want to introduce yourself.
Sure. My name's Caitlin, and I'm with Salem Health Hospital as a hospital billing supervisor.
Thanks, Caitlin. And I know I see lots of familiar faces here today. If you would all like, maybe you can just pop your names and information in chat. And I am going to start off here with the first question. And Tammy, thank you so much for sending some additional questions today. We will be getting these out to all of you after. Today's first question, and I think what I will also do is put all of these questions in chat. Hi, Teresa. So nice to see your name here today.
Although I won't ask, I love to see people's faces.
You know what? I'm gonna do it, Tammy.
Do it. I'll do
If my
it.
computer crashes, I didn't do it. It wasn't me.
Trying to get there. 1 second.
Let's see here. Okay, I'm gonna try this out. Yay! Hi, everyone. It's funny when you start realizing how small the revenue cycle world is when you know everybody at conferences.
Right?
Okay. I'm going to pop each question into chat and then we can have our conversation. We are AI transcribing this today. And so I think that's a great way for all of you to get your questions out there. And then if for some reason we're not able to answer the question today, our process is that we always try to get those answers. And then when we post the questions and answers, we have a little bit more of a comprehensive approach. So here's our first question. This is from Carmen. Hi, Carmen at Legacy Health, and thank you so much for sending this in. For people using Epic, what guarantor type did they use for incarcerated patients? This came up during a meeting last week to talk about the registration process for incarcerated patients and ICE, and we don't have a consistent workflow. Let's see, our official instructions say to use the personal family unless the patient is in custody of the Oregon Youth Authority. Then we use DHS. I feel like we do something similar. The workflow throughout Legacy is a mix of personal family, corporate, and third-party guarantors. The group liked the idea of having these not on the personal family guarantor, and we're split between corporate and third party. Any immediate thoughts? Great question, Carmen. That's a tough one.
Are these limb law, like law enforcement, or are they coming from the prison? Are they being arrested, incarcerated at the time, or are they already incarcerated? Because we have a workflow. Our incarcerations and limb law accounts are set up as institutional. but you have to bill the patient for the first 90 days before you can bill the jails. So it has to be personal family, and then it gets switched back to institutional once we bill that patient.
Okay. And Emily Brown, I see your hand up. Go ahead.
Yeah, I just was going to share that we do corporate for truly incarcerated at Providence. And then we also have a patient type for incarcerated. So then we can have some additional layers of confidentiality and kind of like, for example, we don't automatically send like a ED self-registration notice, right? If they're marked as incarcerated, so we can kind of build some more functionality with that patient type of incarcerated, but it is on a corporate guarantor. And then we do handle arrestees a little bit different if they haven't been booked, right? And then one other layer that might be helpful for folks is that we have a billing indicator that will add on any arrestee or incarcerated. And that actually routes to our HB billing specialty team, and they can kind of handhold those to see, right? Because like, is it NAF care? Is it this? Is it that? Right? And have they done the 30 days, all of that piece? But at the point of registration, adding that billing indicator kind of helps route it that way.
And great, that's a fantastic workflow, Emily. What billing indicator did you set up, and what do you call it?
So it's like so it's well, 637, but you don't need to know that.
Sure.
Law enforcement billing review needed. So
Oh, I like that. Okay. Yep. Great.
We used to have them for specific, like we said, if they were, incarcerated, not arrestee, this or that, but we found that it got really confusing. So and the volume wasn't too much for that team to review each one. So we really opened it up for all states, and everyone is using that billing indicator.
Fantastic. Any other feedback, questions, comments about this question?
So I know at OHSU, we set up a special billing account type for these services. But I have to get back with my people because I wasn't aware of that. Would you say 30 days we have to bill personal family, or what was that time frame?
Yeah, Caitlin, you had a good point there about the time frame, I think, of billing.
You bill the personal family for X number of days and then set up a separate account?
Yeah. Oh, no. So we drop a bill to the patient and then we change it back to institutional. Because
you just drop one bill to the patient?
Because
Okay.
that's the law. The patient has to be billed first before the jail will take ownership.
I'm sure we do that. That's just not like, but we do set up a special billing account type with the corrections, whichever corrections they're with. The Oregon Youth Authority just recently changed some, Andrea's smiling because she knows, they just recently changed the ask for us to send each correctional institution a claim, and not to one, like not to the Oregon Health Authority proper, but to each facility that they're at, which creates a problem for us just because we don't typically set up payer plans unless we've used them X number of times. And so we've kind of have some workarounds around that. But we really need to understand where the youth was in custody at the time that the service was performed.
So this is Eric, I guess, at Legacy. So Caitlin, maybe just what kind of patients are you guys dropping that first statement to?
So Salem is surrounded by Polk, Marion, and then the Salem prison. So we have quite a bit of law patients coming in. I guess that's a good, and it all just depends. If they're coming in from the prison, that would be different. But if they're hurt in the process of getting incarcerated, then it's another different process. And we actually have one person dedicated to limb law, and that's what she does. She's wonderful.
Got it. Okay, thank you. That's helpful because I was like, I don't think I've heard that one, like a patient's incarcerated, from the very get-go. So I wanted to make sure I wasn't missing rules. Thank you.
Now, if they're incarcerated, yeah, if they're incarcerated in the actual prison, then that's, you get them on Medicaid, especially if they're originally on Medicare, because Medicare won't cover them if they're incarcerated. So that's just a different workflow too.
And I think education is important too. Like I know we've specifically educated to what's the difference between an arrestee and an incarcerated patient so that we can differentiate, because arrestees, we do personal family. They're not arrested and under arrest yet, right? They're kind of in for like that legal blood draw or etc. So I think that helps too, to make sure people know the difference.
We actually just set up something with one of the local law enforcement we actually do client bill for those lab draws, because they just want us to take the blood and then they want to process the sample. So it's us billing for just that.
Great. Yeah, this is a really important topic right now, and I feel like timely, since we have been working with the Oregon Youth Authority. Has anyone else had that experience to date with OIA, reaching out to your institution and wanting any separation of like service sites? Not yet. Oh, they will. Don't worry. Maybe once we get that better established, we've got some folks working really hard on it. We would be happy to share the workflow and any learnings that we have from that process.
I guess, Andre, could you just maybe expand on what's being requested, or
I
because I
knew you
guess
were going to ask that,
because
Eric.
we already, I guess on our side, we're already billing some of these jail inmates directly. We
Mm-hmm.
actually have one, I guess, up in Clark County. I don't know if there's any, I think I heard maybe Peace Health doesn't have the problem, but we get quite a few patients from Clark County Jail who has a contract now with WellPath. And that's been a pain point because they're taking so long to process claims. They also kind of recently had filed Chapter 11 bankruptcy, I think, at the end of last year. And so
Oh,
then we were
wow.
getting notices for a while saying like, hey, we filed chapter bankruptcy, like we're not paying you for these things. And yet we've seen some payment trickling in as well.
That's
So
really
anyway,
interesting.
yeah, it's a,
I can share, and I actually just pulled up. And so this is actually specific to, let's see here, because I think there's like a sub caveat here of addiction medicine as well. So we have kind of this draft workflow in place. Essentially, the Oregon Youth Authority initiates a visit. They send us an authorization form. We schedule the patient. We complete the authorization. We utilize the Oregon Youth Authority location, wherever that might be. Our authorization slash billing office emails with patient demographics, the Oregon Youth Authority location. That is then sent to one of our teams. The provider sees the patient, they close the encounter, they go through the necessary EPIC steps. That charge is then dropped to a specific work queue that we have set up. Coding is reviewed, charges submitted, the claim drops to paper. The Oregon Youth Authority authorization form is then updated with the appropriate CPT codes, sent back to the OHA. The OHA then authorizes the payment and returns it to our group, and specifically to that work queue to update the auth number and the payment approval. And then we are able to update and upload that information into the media tab. And I think our secondary step that we're working through is copying that email and authorization forms to the appropriate team. That claim is then printed and then copies of that authorization form. So it is real manual. I think it was manual anyway. I think really the biggest change is the location, right, Tammy? And I'm not sure if, I don't think Melissa's on, but I do see Sunshine in here. And I think that was the biggest change is that before, didn't we just have a process for Oregon Youth Authority generally, and now it's location specific?
Yes, that's exactly it.
Mm-hmm. Does that help, Eric?
Yeah, thank you, Andrea.
Happy to include that in our notes too. All right, I'm
Awesome.
going to
Yeah.
move on
And
to,
Emily,
oh, go ahead, Tammy.
sorry. I was
Yep.
just like, Emily, is the Oregon support person rights the same, like same topic or a different topic altogether?
I think it's
Exactly
different
what I was wondering.
altogether.
Okay.
Yeah.
All right.
Yeah, go ahead,
I just
Emily.
didn't want
Would
to
love to hear
forget.
that question.
Because at the end, then I'll be like, what was my question?
I'm going to make a note of it. So whenever you're ready, you have the floor.
For now, go jump in
Mhm.
now. Oh,
Yeah.
thank you. So accommodating. So we recently had an OHA audit, and they requested that we document the delivery of, so within our patient rights and responsibilities brochure, that's how we have it documented, that they have a right, everyone's entitled to a support person, right? And so that's that Oregon support person is what we call it. And so they also said that you had to document that you verbally said that as well. Now,
Oh.
typically with documentation, so like our hospital consent for services, different, no surprise billing brochures, like these things, we have the document itself and then a corresponding job aid where scripting is outlined. And so generally we say, this is delivered and this is the scripting that was used to deliver this document. In this case, they said that we needed to specifically document that it was delivered written and orally. And so we were wondering if anyone else had kind of encountered that. What we're looking at is updating the document type. So adding actually a new document type. So it's not a true document, but it would be listed as Oregon support person, delivered verbally, and you would mark it instead of received. It'd be like provided orally, right, as like an item. No corresponding, right, electronic document itself, but it would be within Epic's document table. So wasn't sure if anyone had other suggestions or had encountered that or other thoughts on how you would do that.
And Emily, really quick, and so you said this new document type would be Oregon support person. That's kind of how Providence is going to classify that document.
Oregon support person rights, I think.
Oh, okay.
I'd call it, because it's really what it is delivering the statement, right, that you are entitled to a support person. And so it's just to document that it was delivered verbally. I think it kind of surprised us, to be honest, that we had to do that additional piece and additional documentation, because naturally all of our forms have specific scripting, right, and pieces that need to be called out. So just.
And is that done at check-in? Where is that check-in?
Yeah, so we are loving trying to move everything to electronic, right? E-check-in, ED self-rec, right? Like trying to get it, patients can do it on their phone, but this particular one, because it has to be delivered verbally, we can't really, we haven't found a way to do that. So it really would be like at the point of service or pre-service on a call, right?
I haven't heard of that yet. Tammy, have you?
I have not, no.
Yeah.
And can't imagine the burden that, do you have the bill that requires that, Emily?
I have it in my email. Yeah, I can.
Could you send it to?
That would be fantastic. I'm just going to make a note too. Anyone else on the call have any experience with that Oregon support person rights? and any updates that we can give Emily. And if not, we will do some research. And thank you. It's so nice to have these solving sessions.
Well, then at least if it comes up at your org, you can reach out and see
Yep.
what we
We
figured out.
we know a gal here.
I think, for me personally, I struggle with needing to document each verbal component to each document, right? That's going to open the floodgates in my mind to like, oh my goodness, we would have to have a lot of documentation on each piece, right, that you call out. Because our patient rights, for example, has like, pages and pages of rights. And if you have to document each one, like, so.
That's a lot. Yes. Yeah, I'd be curious too, is it for each service or is it within a span of time?
So it's bedded is our interpretation. So we do it for emergency department and also our bedded surgical cases or inpatients.
Okay. Great. Okay, I've got another question to throw in here. I'll put this one in chat. This is from Caitlin. And this is a good one, Caitlin. From Salem Health, we have a question about how other hospitals are handling surrogacy adoption through DHS, where the newborn is forcefully, not through, thank you so much, not through, where the newborn is forcefully removed. When a bio mother who is putting a child up for adoption or is a surrogate, and there is a contract with an agency, if the bio mother is covered under Medicaid, but the contract states adoptive parents are financially responsible, are you billing Medicaid or the AP for all services provided? That is a sticky wicket right there.
So a little history on this one. The mother gave the baby up for adoption 2 days after birth.
Okay.
Which is fine. And we wouldn't think twice about it. Mother's covered under Medicaid. We would enroll the baby in Medicaid for those 2 days. But the contract specifically calls out that the adopted parents are financially responsible for any prenatal, birth, past, and future financials.
I mean, that adds a layer of complexity because it sounds like it wasn't an intended arrangement. And so, I mean, if it's an intended arrangement, I had to phone a friend about this. And so if it was an intended arrangement, we do set the birth mother up on a special billing account, and we associate the adoptive parents information as the guarantor. And I didn't quite pick up on that nuance of like after the fact they made that decision. And so I could imagine we would set it up the same way and just move all charges to the new account type, praying that there's
I can get on board if it was a DHS, where the
you said
state
not.
came in, then you would bill the Medicaid. That would be okay. But the contract is just like, to me, Medicaid's not responsible
agreed, because
if it's going through an adoption.
Like
it's an actually adoption agency. It's not through DHS. It's a nonprofit.
And so, Caitlin, in this patient scenario, we would not be billing the adoptive parents' insurance for any of that because this contract for the adoptive agency takes on that financial burden.
Yeah. Well, no.
So
because the adoptive parents would put their kid, the child, once they receive the child,
right
on there.
And I would assume that could be done retro, right? Emily, I think you are gonna chime in.
Yeah, because I think what it comes down to, so we see in like California, to be honest, a lot of like international deliveries occur, and then there is kind of this separation, if you will. And I think it comes down to guarantors, right? So like you still have mom, and if baby, and within like the nursing grease board, you can choose like surrogacy. And so then if you know, right, you know, and clinical tells, right? So clinical does it first, but then it can be changed by registration. But that surrogacy flag on the grease board is what drives the newborn's guarantor record, right? So it'll pull from mom. And so if that happens, where let's say we didn't know it was a surrogacy, it's going to look like baby is under mom, right? And mom is guarantor and mom is everything. But so you'd have to do it manually to kind of reverse all of that. And then it's a decision is, does it go to adoptive parents? And so a lot of times baby then is covered by adoptive parents. They're then the guarantor. If they're not on coverage, they're not on coverage yet, but that adoptive parent then is responsible for the baby's record. Now mom's then visit, it would be a decision if all of that bill is going to go self-pay and guarantor then is the surrogacy agency or adoptive parents as the guarantor, because then you're talking like, where do those bills go? And then a decision, right? Are you billing mom's insurance for her delivery and then the remainder goes to agency, or are they saying don't bill insurance and it all would be kind of like treated like a self-pay and would go that way? Does that help at all?
It does. I mean, it's just a sticky situation. And honestly, I wouldn't think too much about it, but that contract stops me. I've sent this to legal. I also have my team calling Medicaid to see their viewpoint on it, just to see the rules and guidelines behind that. But I was just wondering if anybody else has do you guys have a good like policy on how to handle these types of accounts and
I think
encounters?
so, but I think it really depends on, in this case, you didn't know going in that it was a surrogacy or adoption, right? And so that gets tricky as far as the information flow, because a lot could be happening with case management and clinical teams, and it doesn't always go to patient access or the billing teams, right? And so you're kind of dependent then on somebody letting us know at some point, or scanning in those official documents or something, right, to then determine. And I think a lot of times that's our biggest pain point is not knowing, right? We didn't know to do this, we didn't know, or who, what, when, where. But then the correction is usually all kind of manual and tedious in terms of where it should go. So if the contract is saying that the agency and or adoptive parents are completely financially responsible, right, then it kind of goes into more like a corporate or
I called the agency this morning and had a great argument with them because they're adamant that the bio mom's Medicaid needs to be billed.
Oh,
but
interesting.
Then they make the same statement that, well, if this was commercial or self-pay, then it wouldn't go to, it would go to the adopted parents if the bio mom was on those. But since it's on Medicaid, see, that doesn't make any sense. So
I'm wondering, I know we've got a couple of our OHSU leaders over the follow-up teams. Any denials management experience on any of your ends with this situation?
I'm looking at the people that are on. It's not over.
I was just going to say, and of course, it's not over that
Pete
team.
is represented here, so that's theirs.
No problem. Good questions.
And I appreciate, Emily, I appreciate the information and that stuff. And like I said, I have it with corporate and legal to look over it. The contract is just putting a wedge and makes my stomach hurt to try and enroll a child in Medicaid when I really don't think you should if it's an adoption.
Yeah, it seems like a very odd one, especially because there could be a retro covered, right, from another
exactly
year, right?
Yes.
So
yeah,
and that gets more hairy.
Okay. Thank you so much. All right. I've got some fantastic questions here that are really industry-wide rev cycle questions. I think that Tammy did a great job in compiling these. These are questions that we probably talk through a lot and always have more feedback on. So I'm going to start here with benchmarks. So here's our first question. What are industry benchmarks for days in AR, denial rate, clean claim? How does your organization in RevCycle compare to its peers and obviously improve the cash flow without increasing the patient burden? Feel free to hop off on or raise your hand. You can hop off mute, or you can put any feedback here in the chat. I know for just my portion in Rev Integrity, which is different everywhere, yay. Um, a lot of our benchmarks, including, you know, different like I'm not going to say days in AR because I'm going to let Tammy talk about that one, but in terms of held claims, any you know, DRG denials or coding holdups, things like that, we really rely on our Epic dashboards, and we do have our own OHSU Health KPIs that we track on a daily basis. We have daily huddle sessions that start with our the frontline folks, and we meet every 15 to 20 minutes, 3 to 5 days a week until we get to our senior director level. And once a week, we review those KPIs, kind of the most important ones, on a dashboard so that we can track over time and trend. Tammy, I know that your groups have some really specific KPIs as they relate to days in AR, denial rates, and clean claims.
Yeah, you know, I think that what started this conversation truly is when we pre-COVID, we, you know, I'm going to start with percent over 90 because percent over 90 is one that it's been super elusive for years, as it turns out. So pre-COVID, we were hitting our goal of 17.5, 18.5% over 90, like consistently. So we actually reduced, I mean, it was 18.5%. That was our goal. We reduced it to 17.5% because we were hitting it consistently. Like insert COVID, April of 2020, our percent over 90 skyrocketed. And, you know, it wasn't a surprise because everybody was trying to figure out what the heck they're doing with processing and managing staffing and that sort of thing. But it has never come down. And so I just feel like the industry standard has shifted, and was curious. I'll share mine if you share yours. Right now, our percent over 90, I think, what was it, 22.1% this morning, John? And it fluctuates anywhere between, I mean, 20 is really good at the moment. But it's been as high as 24%. And I was just curious if folks are willing to share their percent over 90. So I can just say, hey, we're not crazy. Like this is a new industry standard 5 years in the making.
Is there an Epic, like my report or dashboard? Like, do you pull it from Epic to pull
I
that?
don't, because Epic ages from date of service, and we all know that that's not the appropriate measure. Well, I don't think it's the appropriate measure. It should be from the time that service drops. And was curious.
So you export and then just bucket into your
Yeah.
percent.
Terry came on video.
I think, Tammy, everything you just said, you're spot on. And let me just say, in front of me, I don't have it just because I'm multitasking. I'm sorry. But everything you just said, you're spot on. And I'm not sure if you're talking PB versus HB, but
Good
I think the
clarification.
majority of the organizations, and I brought this to HFMA, we belong to a large system rev cycle forum, and I was like, you've got to go back and reestablish what the new metrics should be. Not just because, like you said, we're in the same boat, and it's gotten, from the denial increase, the delay increase, from the down coding that can be even complicated to identify, to contract negotiations, holding claims for
Yes.
months. So I think in reference to that, I recently did, just in one specific area, I recently reached out to a colleague at Huron saying, can we go a bit deeper on just even the denial write-off and the section and the opportunity if we remove the dial? So with that said, our aging is increased. We held claims for one significant payer for almost 6 months.
Wow.
How can I, right? Like, and we tried to get advances, right? And I think we're not any different than so many others. Now that's the longest, and that's ever since like 30 some years in this industry. So Tammy, I think with what you're sharing, I think we actually do need to, and maybe we all do some homework and we come back together. We can pull on HFMA. We can also pull on other revenue cycle industry consultants. You're not out, and and then they have the AI. We're fighting the AI, trying to fight the AI, and we don't have the AI to the level that they have the AI. Anyway, so bottom line is I think this would be a really good session, and for folks to do a lot of additional thoughts on how we could divide and conquer, bring it back, HB versus PB. The other thing is to your point, like and one organization may be writing off at point of billing, the other may not. And then I think, Emily, you're right in terms of like, there are the Epic dashboards. So often we go and make sure we get the ones like us. So, but at the same time, that there could be different workflow, different agreements. So some may be using coding automation, some may not. So anyway, I just think it'd be really good for us to go deeper with this and pull on HFMA as well. Those are just some thoughts, but we're in this together and we're here to partner on this one.
Yeah, Terry, I mean, if anybody's ever gone to CORE, they do have sessions about like your trophies. And because we're all Portland and not necessarily all, we're different too, academic versus not. And I think it would be a great session, honestly, to talk about like pull a handful of the providers up there and really talk about what they're seeing as an industry, because explaining to my CEO or my CFO why my percent over 90 when everything else looks amazing.
Right.
Like, how do I explain that?
Right.
It's just a shift.
Right. The other thing though is maybe take it one step further to talk about deep, top priority, big rock action to take for those key areas where increases are, as well.
Yeah.
I'm with you. I mean, the reason I asked too was like, what is available in Epic? Because I think that oftentimes we see like there could be a little bit more, right? Or could be more specific, right? Like you mentioned, Tammy, is there's like aging, but really we want like, days in work queue, right? Or more specifically to the work stream that they're in. And so maybe that's opportunity for us to kind of group together and say, Epic, we need better reporting for this, right? We want consistent, right, for what we need to see. We don't want your interpretation of what we want to see. We want to tell you what we need.
Does OHSU net down at time of billing?
HB, not PB.
HB, not PB. Okay. Salem, see, that's where we get stuck with those trophies. Salem Health does not. We don't net down till 180 days. And so the trophies don't always resemble the we don't compare the same.
Yeah.
That could be like a whole nother session, right? Is maybe talking about getting or that view, because I mean, same with us, like we have different reasons, right? That we're not, meeting the trophies. They're just not maybe measuring what, we want it to, or what we're striving to really, change. So maybe that could be another session. It's like, what are we all tracking?
OHSU does participate in the Clinical Practice Solution Center CPSC surveys, but it's really comparing academics against academics, and not regional against regional, which would be super helpful because everybody has something a little different. Thank you, Andrea, for that
Thank
We
you.
need to have ask those questions.
Terry, you guys don't net down at all, even after 180? No? Oh, okay. Nice.
I was going to ask you, and that's an interesting concept. I'm not sure that I've heard of some folks. Now I can say from a reserve setting on the accounting side, that too might be even another because it can impact your net AR days, right?
Yeah.
So that's a good question to kind of, further look at as well.
Great. Okay, we ready for another little set of questions here?
Did all of them get answered? Okay.
I mean, I think how do we increase cash flow without increasing the patient burden? Given our current HB 3320 woes, I don't know if there's a way to that's from a patient perspective.
Well, like you said with COVID and everything, all it's done is given excuses on, we're short-staffed. We're, we're behind. Our appeals department, our high dollar review team is behind, because we're short-staffed. That's
Yeah,
all
we're
we
gonna
hear.
hold all of your claims at the beginning of every year for 2 months.
Yep. Yeah.
On that note, let's talk about these questions. Payer and reimbursement trends. So, gosh, this first one is so near and dear to my heart. How are value-based care models impacting rev cycle operations? What are the latest trends in payer contract negotiations? How can we handle payer policy changes more efficiently? And how do we prevent and manage underpayments from insurance companies? I'd love to hear anyone's thoughts on the first question. How are value-based care models impacting rev cycle operations? I know at OHSU, we, upstream approaches to healthcare is really the future of healthcare. But I think that we're all probably feeling a little behind the times in that we know these value-based contracts are going to be coming and they're going to become a bigger part of how we're reimbursed. I think one of the barriers for OHSU, and this is specific to HCC coding, so the hierarchical condition coding methodology of value-based risk model, really focuses on making sure that we have all of the support around family medicine and primary care. And I think, at OHSU, we know that this is a group service line that is typically underfunded, under-resourced, and has really low payments. And so while we know that CMS is pushing all of this, the next 10 years is going to be really, I think, instrumental in value-based contracts. I often wonder, how is CMS and then OHA going to fund some of these payment models more so that we can keep the providers that we need, so that we're not 6 months out, getting our patients into a primary care visit, which is what we're doing right now. And Aaron, so the 270, 271 messages currently do not provide real-time VBCs such as ACO info. Yep. Bundled payment models or capitated plans. Receiving this in real time prior to billing would assist with proper claim submission and reimbursement. That is a really, really good point.
I don't know. How do we bill it?
Yeah.
Andrea, I think back to that very first question, how value-based care models impacting revenue cycle operations. I think about what we have going at OHSU, where we have a CDI team and we have a HCC team who independently work in a silo, I would say.
Yep.
As it relates to revenue cycle operations, we have these teams and we've been lucky to be able to put those teams into place. And it wasn't until recently, like my coders are screaming, why do I have to put 12 diagnoses on a claim? Like at the end of the day, it's so much work effort for them to continue to do this. And our HCC team is like screaming because you have to, but understanding the financial impact, it wasn't until Andrea, I think you sent it to me like
Yes.
or so ago,
Couple weeks ago, yeah.
how much money we obtain from being able to meet certain HCC value-based care models, and the money that it came to the organization. I was like, I sent that to my coding team. This is why
Yeah.
to put 12 diagnoses on a claim. And I think really helping operations understand what it brings to the organization as a whole is missed. It's a missed opportunity
Mm-hmm.
to provide that education.
Great point.
We currently have one payer. I won't say any names. They're actually removing diagnoses to lower our DRGs because they don't agree, and they're not sending letters to explain why they are downgrading or removing those
I'm gonna take 3
diagnoses.
guesses in my head.
Just don't say them because my face will
Oh,
give
I
it away.
won't.
But yes, yeah, currently we have that it's been very interesting. I think I know who. Yeah. But I will say with the payer policy part, one thing that we started doing for the HB side is we created a new adjustment code for line item denials, which fall under payer policies, to start pulling actual numbers for our contracting team, especially
Mhm.
for those payers that, you have a contract that says percentage of billed charges, but then when
Yes.
they remove your charges because of payer policies, your percentage is actually a lot lower than what it's supposed to be. So we're hoping that with more visibility to the dollars that we lose.
And Caitlin, you said it's an adjustment code that you're using?
Mhm. Yep.
Yeah.
We utilize our BDC records, our root causes to start trending. I'm currently putting together an actual presentation to do for our team to show them the importance of doing their BDC records correctly, because this is what we're pulling. And I'm going to use some tips and tricks from Steven earlier on Excel to play with pivot table for them. But yes, it's really hard because contracting doesn't see what we see. Their mindset
Mhm.
is the contract says it. They don't understand that, well, it's percentage of billed charges no matter what. No, that's not true, because contract doesn't say
Mhm.
you won't follow their payer policies and that stuff. So just putting some visibility to the dollars for them, we're hoping.
On the contract side, I'm glad you had this question in here, Tammy. Um, we also work really closely with our managed care contracting department. I think I always was under the assumption that the more specific we were able to get with our contracts, the better. And I think that I'm learning why managed care contracting actually it's not that they don't want things to be more specific. They actually recommend in many cases that you don't make contracts that specific. And so I think there's a little bit of a chicken and egg game that we're playing in RevCycle, where you definitely don't want everything to be called out, and this is maybe more from the contracting side. Whereas I would think and have assumed in the past, the more we call out specifically, the more we can appeal, the more that we can authorize. Just kind of wondering what everyone else is up against right now in terms of working with their managed care contracting departments and specific contracts. Yes.
Yeah, I guess I'll just jump in, Andrea. I guess I know I feel like Terry and I have been working with our managed care team at a whole other level, probably the last couple years, I would think. And we're meeting with them on a weekly basis, which is, I think, just even, our relationship has grown so much with them, I think, at another level as well. And so, I think to your point, we can't, even though we have a list of things that we want, we can't always get. And I think that's just part of the whole contract negotiation piece. But where could we have some of those small wins that are going to potentially help us long term? So, just it's, how do we get that right language in agreements as those are coming up? But yeah, the struggle is real. So
Is so real. One of I think the big problem statements that we have right now is various incredibly medically necessary services that don't have any policies yet, don't necessarily have any carve outs in a contract, and therefore everything has to be an SCA. Oh gosh, single case agreements, Ryan. It's that's the cuss word of the day. Till treatments. I know
Yeah.
Ryan's been dealing with that and just maybe wanted to hear your perspective, Ryan.
I would say, I mean, everything from like now our BMT patients that are having these, when we talk about the autologous patients and things that are not on any contracts. And then when I ask contracting, they're like, yeah, it's not built into their policy. And if they don't build it into their policy, then we can't, require any type of anything in our regular contract. So it's, again, that cat and mouse piece. But even aside from that, like there are all these like little rinky-dink pairs that I'll call them. They're not really pairs. They're they're the clearinghouses that try to negotiate Medicare rates or won't even negotiate any type of single case agreement, just says that they'll pay a Medicare rate. Or we're running into just a whole slew of even the health shares telling patients that they'll negotiate single case agreements for them. And I can tell you our process is super broken. Like the amount of time that we're spending reaching out to contracting, then contracting, reaching out to try to negotiate something that's going to take 30 days. Patients got a delay in care. Providers are upset. Patients are upset. They feel like it's our fault because their insurance companies are telling them that they're, able to do this or able to have, there's no network. You can go wherever you want. Well, there's no network because they're just going to pay us Medicare rates. So I don't know if y'all are running into those same pain points. I'm trying to work on a process within like Epic on how to communicate with our contracting department to try to make it more efficient. But man, the amount of hours that I have spent just trying to talk to contracting about these patients is significant. So I don't know if anybody else has found a better way or has some type of ideas on how we can lobby to have them not be a thing anymore. That would be great.
Any other organizations have some experience with that right now?
Eric, you could maybe even jump in more than me on the details, but we also have seen obviously the success of having the single case agreement because we've had large health plans that were out of network and payers were paying less than even Medicaid rates, like crazy. And it's that non-contracted. So that's the piece where we have seen the benefit, but to your point, this is all just insane. It's crazy. I don't know, Eric, if you want to add anything
Yeah,
more
and
or other systems. Yeah.
no, I guess so. And what I was trying to kind of wrap my head around, Brian, I guess the question is, are you looking at it from a pre-service perspective or post-service? Because I get tons of pre-service. So most of the requests that I get coming to me are post-service where we've already given the service. Now they're wanting to negotiate on the, on the charges that we bill to them. And that, like, I get
Then you have no negotiating power.
No, necessarily, but obviously I know that, in some cases I'm able to execute a SCA, based on what we built and we'll do it post-service, but from a pre-service, I don't typically get a ton of those requests coming my way. And that, I guess, pre-service, I typically work more so with contracting on, and we get far and few that maybe I have to escalate up to him, or to them, I guess, really. So.
And Eric, when you say we already have other folks assigned to doing that, so it bypasses
Mhm.
you for that
Yeah,
front end. So we still have probably
yeah.
the issue though, to your
Mm-hmm.
point. I
Yeah.
wanted to share one other piece, and I won't share the name of the organization just because it was in another forum, but it's a large health system. They work with their managed care, and it's not in the Pacific Northwest, but they work with their managed care team on a significant national payer to negotiate that, like at a certain point, when they saw a certain point of denials, they would have some additional rights. They would have additional um, working through financially. And I can't remember what those details were, but I'll share with you. In order for them to have that conversation, they built in $10 million denial. He said, so the bad thing is we have to hit $10 million in denials in order to then have that conversation. So I was like, oh man. And this is a smart organization. You know what I mean? So
Wow.
to that degree, it was like, oh, I mean, it's like, and we're all trying to play with, not play, right? But just trying to navigate in these waters that are so challenging with this area. So anyway, I just wanted to share that. It's like, as you work together with your managed care team, and we know Guidehouse, we are Guide Point, Boost, Aspirion. There's several consultants that are out there trying to help managed care and rev cycle through this. There's some winners and there's some losers in that scenario. Just wanted to share that.
We
Thank you so much.
we see a lot of single case agreement actually in California, and have recently been talking about a use case for increasing for like out of network, right, or non-contracted. And so how we do an alert that prompts at, so to your point, Ryan, is like a pre-service. We want to catch it prior, right? They're, maybe they get through scheduling or we're at the point of scheduling, and how do we get that, alert to fire that we need the single case agreement. And I do have a full workflow we can, offline I can share with you, but really it does involve like having it on file, scanning in, the agreement and putting in billing indicators, right? And having it kind of route appropriately as it goes through.
Feel like we could have a whole work group maybe at our next HFMA just on single case agreements. That might actually be a good panel for us to look into.
Yeah.
I know we only have 3 minutes left. These always go so fast. Before we wrap up today, I did want to do our fun little spin for gift cards. We had 3 main folks send in the questions, and I should say 4. Tammy, I'm gonna throw you in here if you'd like me to. No? All
No,
right, we're
no,
gonna give
good.
opportunities. Okay. So for our first $25 gift card, I'm going to show you the wheel because I just think it's so much more fun when you can see the spin happen. Give me 1 second here. Okay. Can you all see the wheel?
Yes.
Okay. Here we go. Click number 1. Yay, Carmen. This is a little bit unfair since there's technically only 3 total people for the 3 gift cards. So the good news is every one of you gets a gift card. I also know because we have done this virtually, it's a little bit different in person. And so Carmen, Emily, and Caitlin, you will all get a $25 gift card. Before you go today, I would love for each, and Eric, maybe you can do this for me. If you could give me your personal emails, I'm going to put in the chat my OHSU email. I'm going to stop sharing here. So for some reason, some of the gift cards weren't getting to folks. They were going into their spam with their work email. So I'm going to put in chat here my OHSU email is right here. And if I could get Caitlin, Emily, and Eric, if you wouldn't mind on behalf of Carmen, sending the personal emails so that when we send you those gift cards, they don't go into your spam email. That would be fantastic.
Yeah, I'll reach out to Carmen and ask her for hers so she can submit it to you, Andre.
Perfect. Thank you so much. Any last thoughts before we end today? I so appreciate all of your time.
I love these sessions, so thank you all.
I need more
Yay.
time, more than 1 hour.
We need more time. We will be holding more virtual problem solving sessions. So, you know, keep updated, and we will definitely be advertising on social media and with Oregon HFMA websites. Thank you so much,
Thank you, guys.
everyone.
Thank
Have a
you.
wonderful
July,
day.
everyone.
Bye, everyone.
Bye.
Bye.